interested to investigate the extent to which commissioners in the health service in England are actually seeking to bring about better integrated care. And I emphasise the point that it was commissioners that we were interested in, because we've done lots of work at the Nuffield Trust exploring integrated care provision and how that operates. But what we hadn't done was to try and understand who is it who actually brings this about, who tries to incentivise different forms of care provision. And if what we call commissioners, the purchasers and planners of care, are going to do that, well, how might they go about that? And to what extent are they successful? Or what perhaps gets in the way of progress? Probably the overriding message from the research is that it's tended to be providers rather than commissioners who've been carrying out work to bring about integrated care. And following on from that often attempts to develop integrated care have been often perhaps one-off, or they've been for just a particular service or a particular client group in an area. And I think what our research suggests is that it's time to be more bold, that we need some experiments of integrated care at scale. But that if commissioners are going to bring that about, and they need to, given the efficiency challenge we face in this country and other pressures such as the ageing population, but they're going to need some help in that, some direction and support from the new NHS Commissioning Board, perhaps some freeing up or adaptation of some of the policy levers that are currently available to them. But I think the really encouraging, perhaps final message from the research is that this can be done, and that there have been some really interesting new service developments for people with heart disease, with diabetes, people with complex conditions, older people. So if this can be done under what's been arguably not always the easiest of policy environments, it could be so much more extensive in the future. Well, what we did in terms of going about the research was we carried out a national survey of all primary care trusts in England, which at the point at which we were doing the research were the main commissioners of healthcare. And we sent out the survey to them, asking them about initiatives that they were seeking to bring about to lead to better coordinated or integrated care for local people. Now, we had quite a disappointing response to that survey, so we widened the net a bit, and we also contacted long-term conditions leads in strategic health authorities, and we also talked to some national organisations with an interest in this area. Now, that proved more fruitful, and we did end up with quite a long list of examples of where commissioners were seeking to bring about integrated care. And from that, we selected 8 case studies, which we went and investigated in more depth, talking with doctors, nurses, managers, and of course the commissioners, to find out how it was that they decided that they needed to bring about this particular service development, such as, for example, a new approach to diabetes care for an area, or perhaps quite a bold attempt to reshape the way in which care for people nearing the end of life was designed and delivered, and then talk to them about, well, how did they actually go about that? How did they try and influence hospitals, GPs, community nurses and others to actually work in different ways to bring about that better integrated care? Yes, well, I say we were particularly interested in the commissioning of integrated care. So in the report, we actually take the different elements of commissioning, such as assessing needs, drawing up service specifications, the processes of contracting and procurement, and we look at each of those and draw on the case study examples to identify lessons for commissioners when they're trying to really reshape care in quite radical ways as to what they might need to do. Well, it's interesting you should ask that, because researchers and analysts, ourselves included at Nuffield actually, have often been quite hard on practice-based commissioning, suggesting that it hasn't been always terribly effective in bringing about the sort of significant service change we need in this country, particularly in terms of moving care from hospital to community settings and having better integrated services. But in the case studies we examined for this research, we found in a number of instances that in fact it was GPs who'd been active in practice-based commissioning who had often either come up with the idea for the new form of service provision or who had gathered together management and other support as a way of driving forward the particular initiative. Well, I think what we found in this research was that the work that had gone on to develop integrated care through commissioning had to quite an extent almost happen beneath the radar. And that looking back on it, the past decade, national policy had focused very much on the use of often competition or related approaches to really try and change and improve elective care. I think what hadn't happened to the same extent was a focus on non-elective care, care for people with chronic disease or complex illnesses and difficulties for people who are older or nearing the end of life. And those are conditions that we know are much more amenable to attempts to integrate care. So I think that's why in the case studies they'd almost been either trying to adapt and mould the policy levers, the payment approaches that were available to them, and I say almost getting on with this rather than having been told to do it by national policymakers. Well, I think first of all there is a need to address commissioning itself, and that's clearly being done as part of the current NHS reforms, with attempts to strengthen commissioning through having an NHS commissioning board, which I think can play an important role in developing some sort of national guidance and standards around integrated care, perhaps helping local commissioners with things like the forms of contract they can use or payment approach, in a sense giving them a bit more permission and guidance in this area. But also the establishment of new clinical commissioning groups, which will be wider than just general practice, involving hospital specialists or nurses. Again, I think there's a real opportunity there to develop these sort of approaches and again to use commissioning as a key part of that. And in addition, there are other policy changes that I think are emphasised by our research, such as the need to balance policy on competition with an appropriate focus on collaboration and integration. So messages in our research there for how regulation will happen in the future. And another area in which I think our research can speak to national policy is suggesting that when it comes to the payment mechanisms and arrangements that are available to commissioners, that the regime we have at the moment, called payment by results, that could be extended and used in perhaps some different ways to enable the integrated care we point to in the report. So, for example, much more experimentation with what the Americans and others call bundled payments, where you link together the payments for general practice community services and perhaps hospital services, so that contracts can be used in some more sophisticated ways to make it easier for commissioners to actually get different organisations to work together for the benefit of new forms of services for patients.